Thank you. Can you hear me okay, or do I need a microphone? Can you hear me? Perfect. Okay. So, thank you very much for being here. Thank you, Michelle, for this opportunity. It's really very nice to be here and present to you guys our last update. So, this project started this project actually. I'm going to be talking about two different projects. They started about 3 years ago, so what we deal with, what we have been dealing with, is the common phenomenon of central nervous system oxygen toxicity. Now, allow me a question. How many of you guys are divers? One, two, three, four, five. Perfect. Okay. So some of you will be familiar about what I'm going to talk about, but for those who are not, I will explain what this phenomenon is. But let's start from the beginning. This is our sponsor, Office of Naval Research. So we work with the Navy. The director is Professor Jaylin, and this is some pictures about what they do. So these guys are often in missions of attack, defense. They're underwater for submarine rescues. Sometimes they're under stress. So they have to deal with a lot of problems related to their job. And this is our gas palette, what Dr. Dean loves to call gas palette, which includes a variety of different gas mixes that we have here to mimic what a Navy diver, Navy SEAL diver is. So with these gases, we mimic sometimes harsh conditions that divers have to undergo. So let's talk now about the big problem that we have faced when we started this project. So when we dive, we use regular air. We have a gas mix of about 21% oxygen and 79% nitrogen, roughly. So the air we're breathing right now. When we breathe this gas mix under the water, the deeper we go, the deeper these gases are compressed. Now, the problem doesn't come actually with oxygen, with the oxygen component, that's 21%. The problem is related to the inert gas, the nitrogen. When we have a lot of nitrogen under pressure, so let's say 2 atmospheres, 3 atmospheres, and let's consider 1 atmosphere every 10 meters. If we surface very fast, we don't allow our body to eliminate that inert gas. So that gas is called inert because it is not metabolized by our system. So the problem related to surfacing too fast is that we can have vents. Now probably some of you are familiar with the vent. We can have emboli, which is one side of the vent, or we can have simply the vent, which is accumulation of nitrogen, usually at the joints, which results in pain in the best of cases, but can also result in blindness if it accumulates on the optic nerve, or we can be paralyzed if it accumulates in one of our vertebrae. So it can be very variable. So of course, the main advice to the divers is to surface very gently to include the safety stop and then surface. Now, the point is that during these missions, usually the divers don't have that kind of freedom. They have to surface maybe faster, or they finish their reservoir of air. So in order to avoid the problems with the vents, a long time ago, they started thinking, okay, why don't we increase the percentage of oxygen in the tank so that we decrease automatically the percentage of nitrogen, right? It makes sense. So they increased more and more, up to 100%. And that's exactly what people do with these things called rebreathers. So 100% oxygen, we don't have any nitrogen, we can surface as fast as we can because we don't have the vent. That totally makes sense. Well, they started dealing with a new problem, which is called central nervous system oxygen toxicity, which is seizures. It's like epilepsy. I will show you a couple of videos about that. So, the seizures, when you imagine an epileptic patient right here in this room having seizures. Well, he will lose his consciousness if it's grand mal seizure, but when he wakes up, or she wakes up, he or she will not remember anything. But again, he will have some bruises probably, but that's it. It's not like a life-threatening kind of pathology. It doesn't kill you. when this happens underwater, most likely they die because they lose the regulator, and their body, their diving body, is not able to put the regulator back in their mouth because in most of the cases the jaws are contracted. So that was the big, huge problem of the Navy. So they started asking us, okay, number one, how can we predict this? Number two, can we prevent this? So when does this problem happen? Basically in two cases in real life. Number one, when we treat patients in hyperbaric chambers, because we give them too much oxygen and depression, or with, usually with rebreathers, but when we increase the percentage of oxygen in our gas tanks when we die. So, as now, the limit for the Navy is very conservative. We can only be 10 minutes at 50 feet breathing pure oxygen. Can you imagine 10 minutes? It's nothing. But, you know, the shallower we go, the more we can stay underwater. So now, one of the objectives of our project was to extend this limit. So this is how it looks like. This is how this is what a seizure underwater. This is, of course, this is they're just mimicking a dive here in a hyperbaric chamber. But this is what it looks like. So on the right-hand side, we have a physician who's breathing regular air at 2.8 atmosphere. So we're talking about 20 meters of depth. Okay? On the left side, we have our pilot for the Air Force, the American Air Force. He's breathing pure oxygen at this point. So they are the same depth. One is breathing air, one is breathing oxygen. And see what happens. So it's saying, hey, I feel kind of dizzy. Can you please take off the mask? Sure, take off the mask. Not a big deal. Well, he's feeling kind of bad now. So he lays down. The physician already knows what's going on. He's going to have seizures. So things feel okay. So now, in about 3 seconds, he will lose his consciousness. And if you look at his legs, the next 3 seconds, you'll see contractions. Keep looking. There you go. Now he's totally unconscious. He's seizing as in grand mal-like epilepsy seizure. He's now seizing. He's unconscious. He will wake up after 5 minutes, not remembering a single thing. Now imagine all days under the water. He doesn't wake up. He just dies. So, we started off studying, actually, Dr. Dean, before I joined the lab, started studying the cellular and molecular mechanism of this phenomenon. And this is how our lab looks like. So we have several hyperbaric chambers. Some of you have been there and know that that place is kind of unique in the world because we have like so many chambers, and this is specifically something called atomic force microscope. It's something that is able to make a topography of single cells, or neurons, under pressure. You won't find this anywhere else in the world. So they started off working on hyperbaric atomic force microscopy and mapping what happened to the cells, especially to the neurons, after a huge burst of hyperbaric oxygen. So let's start from the origin. This is a paper that Dr. D'Agostino published in 2009, and he demonstrated that basically a cell that is, so we're talking about glioblastoma, so it's a brain tumor. And when the cells were treated with hyperbaric oxygen, their membrane, their topography, their structure was completely disrupted, as you can see. So not only hyperbaric oxygen is not very good for our neurons, but also we have the production of this free radical called superoxide. Free radicals are generally bad for us. You know that. Actually, free radicals are those which cause the seizure, the onset of seizure. Superoxide is one of those. It's the most present one. So as you can see, the more we increase the oxygen, the more free radicals, the more superoxide we have. The closer to the red, the more superoxide we have. Not only the bigger production of radicals, the bigger quantity of oxygen we give them, but also the bigger the quantity of oxygen was, the more we could experience cell death. So as you can see here, unfortunately the label just disappeared, but we have here 95% oxygen, 60%, 40%, and 20%. So the more oxygen we give to the cells, the more they tend to die. The other thing that Dr. Dean and Dr. Giardestino have been working on for the past decade has been mapping basically the excitability of the cells under pressure. So not only the cell death, not only the free radical production, but also how excitable is a neuron under pressure compared to neurons that are not under pressure. Well, and they have all this wonderful setup that I invite you to come and see if you haven't so far. And that's via these images that I come to the actual project. So we started off working in vitro. So we took some of those lyses from brainstem, from the solitary complex, which is an area that integrates respiration in rats, humans, and everybody. And we started working on the excitability of this cell. So Dr. Dean and colleagues found out that this kind of neurons from the solitary complex in the brainstem are highly excitable when treated with hyperbaric oxygen first. So we give them hyperbaric oxygen, as you can see here. Their excitation, their firing rate increases. Also, they found out that the neurons that were highly excitable to hyperbaric oxygen were also highly excitable to carbon dioxide. So the mechanism was probably similar, and that's in fact what we've been exploring in the future. So we came across this idea, and Dr. Dean got this grant, which we had to analyze this phenomenon in animals, in live animals. So how did we do that? We took our rats, our lovely rats, and we implanted them with this module, this device. So these are called radiotelemetry modules. We are able to record at the same time different channels. In this case, it was electroencephalogram, 2 channels, electromyogram from the diaphragm muscle to record the respiration, and the electrocardiogram, plus core body temperature and physical activity of the animal. All these in real time. Then, these modules, when activated, they would communicate the data and transmit the data to the receiver, which is connected to the computer. All this package is within a hyperbaric chamber that some of you have been observing actually. And there are some penetrations from within the chamber, and there are cables that go to the computer, and we record this data in real time. Then we compress the chamber. 5 atmospheres. We're talking about 40 meters of seawater. In air, in this case, in the big compartment, and oxygen in the small compartment. Of course, we want to mimic a Navy SEAL diet, so we need to use 100% oxygen, but we cannot use oxygen in the big compartment because it would be too risky in terms of it's flammable, and also because it would damage our receivers. So we only concentrate the oxygen in the animal compartment. We still free to move around, so it is unrestrained. Then we compress the chamber, and we release the dust. And this is what it looks like when the animal is just resting, just being there during the control period. This is how it looks like when he's having seizures. So when we get close to the point that the animal has had so much oxygen, hyperbaric oxygen, that's the way he starts seizing. He will sit down on his back paws and have some tonic movements of forward his head. This is very typical in rats. It's a very standard pattern. Now, when they reach this point, we stop the experiment. Of course, we don't go over that. And we decompress the chamber back. So we want to analyze at this point basically what happens to all the other physiological parameters before the onset of seizure in order to predict a seizure that is just incoming. And this is what the record looks like in the end. So we have the chamber pressure that at some point increases. Now we have the 2 channels of the electroencephalogram that tells us right here that we have the seizures right now, at this point. And we have 3 channels of respiration. So this tells us how the animal is breathing. Especially with this software, we're able to record 2 things: how deep it's breathing and how fast it's breathing. And also the physical activity here. So what did we find out? We found out that about 1 to 8 minutes before the onset of seizures, as you can see here, the animal starts breathing more deeply and faster. So there is an increase in tidal volume and in frequency. Also, so this was the first warning sign that we identified. So we told the divers, okay guys, so if we are able to identify your respiration pattern and we see that there is an increase, a considerable increase of ventilatory response before the onset of seizure, probably you guys are going to have a seizure. So let's try at that point to surface or to switch to air, not to pure oxygen, so that you have the time, even during a stealth mission, to find a safe spot and surface, because most likely you're going to die. This was the main finding. But also now we have to find out how to prevent these seizures to happen. So antioxidants, sure. I mean, everybody knows that. They work, but these are very harsh conditions. So would they actually really work? Well, anti-epileptic drugs, they actually made the connection. We said, okay, let's say carbamazepine. The whole concept is making your neurons less excitable than they would be. So probably they would work, but that's a very harsh pharmacological procedure. So let's try gas preconditioning. Gas preconditioning in the literature has been working for stroke, for ischemia, for a lot of conditions. But is it possible to give our animals a sort of vaccination, a gas vaccination, that will make them more resistant against seizures? Just breathing a specific gas mix, like making our brain adaptive to this change in order to be more resistant, to neuroprotect against the seizure. Well, we did this with the maxillary chamber, so we preconditioned them at milder conditions. Instead of 40 meters, instead of 5 atmospheres of pressure, we only gave them 2 atmospheres, only 10 meters, for 3 times a week. And then, so let's say on a Monday, on a Wednesday, and on a Friday, we would precondition them, and then on a Saturday, we would dive them on a deep dive and see what happened. Was it better? Was it worse? So this is what happened. Now I'm going to go through this slide with you. This is the control. So what we are observing here is the number of minutes, so the time, the latency time to seizure for the animal. Each group has 9 animals, so it's kind of a large amount of animals. Here we have the control. So we only gave them 3 treatments of air. So in air, usually an animal would seize in about 28 minutes. So we said, okay, let's try the treatment with 3 exposures to 1 atmosphere of oxygen. So just normal baric oxygen. Well, giving them 3 treatments of oxygen didn't change anything. So we thought, okay, let's try to give them helium, nitrogen, or hyperbaric air, or even hyperbaric oxygen. But let's try these 3 mixed first. So helium, nitrogen, and air. Let's see if this helps resisting more against the seizure. And actually, that was a disaster, because their resistance to seizure decreased tremendously, 78, 57, 40%. So we thought, okay, let's try actually to fly them. Because if we give them like a vaccination, if we dive them very mildly 3 times, and then we dive them for a deeper dive, and it doesn't work, maybe if we fly them, that would be the opposite. And well, yes, they resisted 56% longer. So we thought at this point, okay, is it just the pressure? Because when we fly, we have less pressure. So is it the hypobaric condition? Or is it the hypoxic condition? Because when we fly up over 10,000 feet, we don't have any oxygen. We have very, very low, very lower amount of oxygen. So we thought, okay, let's try, in this specific case, to have normobaric hypoxia. So we still give them the same amount of pressure, but less oxygen. Not 20%, but 10% oxygen. Well, it didn't change at all. So we said, okay, let's try now the same amount of oxygen, but less pressure. And that was really worked. So we know, as a matter of fact, that intermittent flight before the actual dive would actually decrease the risk of central nervous system oxygen toxicity. So diving at an altitude of about 16,000 feet for 3 times, and then taking that dive would probably help them. And that's the second thing we told them, that's the second take-home message. Mechanism behind that, well, we would like to know. We don't. We just found it out. And there is not such an explanation in literature so far, so we could only hypothesize so far. And we could actually say that yes, it could be because there is a liver peroxidation modification. It could be the hyperbaric pressure per se, which is one of the things that we believe now. It could be also the hyperbaric pressure per se. Also, it could be related to the membrane fluidity or the cytoskeleton configuration of the neurons. It could be also related to the mitochondria. It can be a lot of things. So we have this second finding, and now we are going to explore the mechanisms. Now let's go to the second process. The second process is related to Sudafed. Now, how many of you know Sudafed? How many of you have been using Sudafed so far? At least one in the lab. Perfect. Okay, so quite a good number of you. So Sudafed is a decongestant, and is able to let us dive. If you're a diver and you're congested and you don't want to miss that occasion, you want to still go diving that day, yes, you take a couple of pills of Sudafed. And each one is 30 milligrams. So you can take 60 milligrams, your body takes 3. Well, this is a sympathomimetic drug. So, kind of excite our neurons in some way. Well, these are some cases. That's the reason why then Divers Alert Network contacted Dr. Dean and said, hey, we have this problem with Sudafed. Can you actually try to understand why and how this goes on? So there are just some case reports from them telling that people would take dives, especially cave dives, or technical dives, and they would take several medications, or in some cases just the Sudafed or a decongestant medication, and then will die. Well, some of them would have seizures, little seizures. Some of them would die. So Divers Alert Network was concerned about that. They wanted to know if the Sudafed was really dangerous. So we did the study, simple study. Actually, we're going to submit hopefully in a couple of days. We had to do this, of course, for male and female, because we found out that the outcome was completely different. Male, very regular, then linear. The more we gave them, the quicker they see. So we started off with a hammer dose, 320 milligrams per kilogram, which is exactly the half dose of the reported lethal dose of the drug. Well, what we found out is that there is a very nice correlation between the dose and the latency of seizure. So if we give them a dose as low as 40 milligrams per kilogram or 80 milligrams per kilogram, they would seize in the regular 25, 28 minutes as the control. But when we increase the dose, we have fast seizures. So, take home message, high doses of Sudafed can increase the risk of seizure. So, this doesn't mean do not take any Sudafed anymore. That just means do not opt in more than 6 pills before you go diving, because there is high risk that you might see. So we did this with females. Well, correlations didn't come through, and of course we have to deal with a lot of other problems. And actually this study is still ongoing. So this is the male versus the female. That means that the susceptibility to seizure in female was much higher. So we still have to increase the number of animals to have a consistent response, to have a significant response. Well, the alternative conclusion is, of course, the men come from Mars, and we don't really know. Well, okay, so the Navy was happy. We had kind of a solution of, gas preconditioning. We fly them before we dive, and so take 3 flights before you dive, or maybe 5, and then resist more against seizures. Nice. How does it work, though? I mean, it can be complicated when you are in a mission, when you are in Iraq, or it can be complicated. So, what about starvation? Now, some of you might be familiar with the concept. Why would you starve? Why would you fast? To avoid seizure. What's the concept behind that? I'm going to get there. But there is a lot of literature that you can find on PubMed or on Google. You can just look for it. And I will present some of these cases. If you're more interested, you can email me later and I can send you as many pieces of information